So my name's Dr. Karen Miller. I am a trainer, have been a trainer for many years. I work at Adelaide Medical Centre. At the moment, May is my registrar. She started in the summer and will be with me for the rest of the year. And I've been asked to talk about spotting the sort of sick kid and adult and some red flags and the idea of safety netting. So the main thing I think is this, the traffic light system, okay? It's a nice basic what to really look out for, the green, the amber and the red. And most of us have this stuck on our wall. The thing I've also added to my wall is an additional one. I like to know the expected sort of pulse rate and heart rate for children of sort of all ages. So I've sort of slightly expanded mine to have that as well. But I think this is the one thing that you should really have. You know, the green here is, you know, basically a normal child, normal well, nothing to worry about. It's when you start getting some amber is when you need to think, do I need to be thinking about getting a paediatric review? And like the Royal Free, you can phone up the paediatric consultant, discuss the case with them. Will they just want to see them in a, you know, that day or the next day in one of their urgent clinics? Of course, if you have anything red at all, that's straight to A&E, don't pass go type thing. All right. But it's the amber that I think worries most people. So they're a bit tachycardic or they're a bit tachypneic. And this is the time when, you know, most of us are sort of, not sure, what should we do? And it is nice that there is a paediatrician consultant who's basically on call the whole time that you can discuss cases in the amber. And I will slightly come back to this when we're talking about different cases and why you might want to do certain things. Now, you can go and find these most amazing, intricate referral setups, and you just look at that and think, oh my God, it's too complicated. But that, as I said, is the most important bit, and that's the thing really to have on the wall. The rest of it, you're lucky if you can read it. And at the times when you need just the basics, I would very much stick with the traffic light system and just go with that. And go with your gut feeling. I'm very much someone who believes in the gut feeling. If you're worried about this child, get advice or send them in, even if it's just a little bit. Parents are usually really, really understanding, especially, you know, the Friday afternoon, the kid's probably all right, but what if? And children can go off very quickly. And so can the elderly and the frail as well. So I very much believe in one's gut instinct and to act on that. I just wanted to show you, these are two really good sort of web places. Okay, so I'm going to see if I can show you one of these. Let me just unshare and then let me share and get this up. This is the first one, and it's Kingston Hospital. And this side is all, again, a bit complicated, but it's got the main green, amber, red ideas. But what I really like about it are these are little areas here with the fever pathway, and what to do, headaches, head injury, etc. A good example I like is the atraumatic limp in a child. It can tell it, you can then go on here, what sort of assessments should you do for the different age groups. It's got red flags, what are things to really look out for. All right. And the referral information, if you're not sure, the lovely thing is you've got this guidance here. So if, God forbid, you phoned up the PED and they said, oh, I don't need to see you, you can actually slightly use this and say, well, actually, the guidance says because of this red flag, they ought to be seen. So I really like this area for information. There are so many different websites, so many different places that you can go to get information. The Royal College of Peds and Child Health has got loads of information. And this other site here is all about you know, information for COVID mainly. But their website has got loads of information. But I just like the Kingston one and how it works and just the way it sort of is displayed. You know, cow's milk allergy in kids, oh, that is a regular thing that comes up. and it gives you a really nice way about, what to do, what not to do in any investigations, whether you need to refer, etc. Don't need to use their referral, of course. We can refer here, but I just really like their website. So that was just something I thought you might, and especially if any of you are thinking about doing your AKT and etc. and wanted some place that gives you lots of information, I just found this one really helpful. But that is sort of just what I like. You will all probably find your own websites that you like and want to go to, which is fair enough. Okay, so I've basically done this as cases, so I was hoping you guys might be slightly interactive and talk. I know most people are very frightened about talking on Microsoft Teams, but it's really nice if it's slightly interactive. So this is our first case. This is a 2-month-old little girl. She had her first vaccinations 2 days ago, given at your practice, and the mother has recorded a 38.5 temperature this morning. She's understandably worried. First time her child has had a temperature. So what do you want to know? Anyone going to say what they might want to know in this case?
So any other symptoms, for example, if they're eating and drinking well, if they're having wet nappies, and if they've given him anything for the fever.
Fantastic, excellent. So any other questions you might ask specifically? Go ahead, any of you.
Clarify what vaccination she had.
Extend that for me.
I know that some of them can cause fevers in children. So is it the meningitis one? I can't off the top of my head remember which one you have at the first vaccinations, but yeah.
Well done, absolutely. So it's the meningitis B vaccine. Do any of you know what is now in the Red Book and what all mothers, fathers are told to do when they're having their first vaccination now?
I think, isn't it give paracetamol before they have it?
Yes, around the time of it, and then 3 dosages afterwards. Okay, so just a quick thing here. So the meningitis B vaccine, it's given at 8, 16, and then at 1 year. You find at the 8 and 16 week, they need to be giving paracetamol. All right, usually within 1 hour of the vaccine, and then they usually need a further 2 doses 4 to 6 hours apart after that. Some children will continue to have temperatures and can do for up to 3 to 5 days, so you can carry on with the Calpol, okay? They usually say the meningitis B at 1 year, you don't need to give Calpol for it, okay? They usually don't have such a reaction, all right? Okay, and thankfully the meningitis C vaccine doesn't seem to generate, and they also get that around 1 year, doesn't seem to generate the temperatures. It really is just this meningitis B. And back in the old days, before meningitis B, we were always told not to tell them to give paracetamol. You're worried whether it would interreact. And some people who've maybe had other children may not know that the now new advice is for them to have paracetamol when they're having their first vaccinations, and again at their 16-week vaccinations. Okay, but if this kid has still got a bit of a temperature, what would you do? How would you safety net in this situation?
I would say reassure and say as long as the temperature is improving with paracetamol, that's one thing to be look at. If it isn't responding to paracetamol and they persistently have a temperature, then to get back in touch.
That's right, because she's day 2. This is within that sort of 3 days. If they get to day 3, I would usually advise this child probably should just have a see a doctor, just to have a quick check. Is it something totally different? Of course, the things we worry about in very young children are UTIs. Okay, so the important thing is safety netting with this mother, saying in the next 24 hours this temperature should settle. It's good news if, as you said, that it's coming down with paracetamol and is settling. But if she's still got a temperature at day 3, I would say she just needs a quick eyeball to check on her. All right. But as my little picture, it's a lovely, healthy little baby, absolutely fine. And I think most here you can reassure the mother, but the safety netting is to say that if it was still to continue, then yes, just get the little kid to be looked at. So that's just the thing about meningitis B, because we do get calls quite a lot with mothers slightly anxious on day 2 that the kid's still got a temperature and should they do anything about it. Okay, so this is case 2. This is a 3-year-old boy. Mother is reporting 3 days of worsening shortness of breath. He's coughing a lot. He's breathing fast. She thinks he's wheezy and he's not eating because he's coughing. What other information might you want? Anyone?
Is it a productive cough?
So she's going to say it's a barking cough.
Okay.
Is he able to drink if he's not eating?
Okay, so he's drinking some. He is still passing urine at the moment. Not as much as he would normally.
And is he still playing as normal, or is he being quite fussy?
So he's been fussy. He's not he wants to be with the mother, wants to be hugged, wants to be held. Anything? Sorry, go ahead.
Sorry, I was going to say just any temperatures or fevers.
So he has got a mild temperature, about the 38 level.
Any new rashes?
So she's not noticed a rash. What else might you ask her to look at, though?
Maybe his chest and his breathing. So
Absolutely, yep. So is he using the intercostal muscles? That's an important one. Now, how could you assess the child further? Now, when we were in total lockdown and we were having to assess children via video, you were then having to assess them that way, although I confess I was bringing any child under 5 who was what I called a hot kid. I was bringing them in, but I know some practices weren't doing that. I would say now in this opening up climate, this kid needs to be seen and that you need to see them ASAP. To be honest, my team here know that any unwell kid under 5, they just book them in for me to see. But I know that's not the same in a lot of places. So you may well be having a telephone consultation or a triage consultation or maybe an out of hours session. Okay, and the important things that you may need to ask here, because what do we think? What are we thinking about? What is the most likely diagnosis here? Anyone let me know?
Croup.
Absolutely, that's the most likely diagnosis, and that's what we need to. The problem, I would say, with this sort of like COVID pandemic, it's as though all these children's immune systems are sort of shut down and don't seem to have really been triggered at all in the last couple of years. And we're now finding that a lot of kids now back at school, nurseries, etc., illnesses that hardly affected them, they seem to be much more affected. It's as though their immune systems just don't know what to do. And you're seeing some slightly sicker kids with just things like croup. So this is our little boy who's obviously upset. He's not happy. He's mouth wide open to breathe. He's not a happy little chappy. So he is croup, all right? So croup can be caused by a number of different viruses, okay? Usually starts from about 6 months, can go up to 12 years. You usually do see it under the 5s, though. It's rare to see it at over 5, the peak age being 2 years. Boys are affected more than girls, and I don't know why that is. It's definitely in the fall and the winter months. We always have to think of epiglottitis. I have to say, guys, I have never seen a case of it, although when I was doing paediatric A&E, I did think I'd seen 1 or 2 cases, but they were all proved not to be. All right, but do think about foreign bodies, kids, Lego, those type of things. And diphtheria had a rebound for a time. And so pregnant women are now having vaccinations against diphtheria because we were having such a rebound of it in young children. Okay, so there's this big thing about mothers wanting to give them humidification, through those machines and stuff. There's no proof that they actually make any difference. And so really it's when you see the child, you needing to do the oxygen saturations and looking at their chests and recording, are they tachypnea, are they tachycardic? If they are either tachypnea, tachycardic, as on our traffic light system, that's in your amber, and I would be thinking that they need to go in. These kids go off really, really quickly. I had the weirdest scenario in sort of lockdown where a couple of parents, they're actually from, I think it's Brazil, and they phoned up saying, oh, our kid's got croup again, regularly gets croup, just needs dexamethasone, can you do a prescription? And I was just like, not something we normally do in primary care. They usually have to go into hospital for the dexamethasone. Okay, so I was a little bit curious, and they were saying, oh no, he's fine, he's not too bad. I said, I want to see him before I decide on any treatment. And I brought him in, and he's probably the most tachycardic use of accessory muscles I'd seen for a long time in primary care. So I sent him straight into hospital, and I'm pleased he did, since he stayed in for a few days. So it's amazing. There are some mothers who are very anxious, and there are others who seem really laid back. This is the first time I've seen people quite so laid back with really quite such an unwell kid. Most kids with croup, though, are very mild. Most are just unsettled, unhappy, barking cough, a little bit wheezy, but most of them, their saturations are fine. In most cases, you can just safety net saying, if they start using intercostal muscles, if they are breathing fast, then it is back to us or A&E, depending on time of day, etc. But they can go off quite quickly. All right. So just to be aware of that. So, any questions about croup?
Yeah, in the scenario that you just described, where, as you said, you've got a like a child that looks quite settled and quite well, but they have croup, would we still initiate steroids in primary care, or would we?
Don't. Officially, if you think they need dexamethasone, they should be assessed in A&E. That is our advice here at the moment. There are some places, e.g. abroad and other places, where they just give them dexamethasone straight away. You can give prednisolone, and I have had a couple of kids who've been assessed in A&E who've had a dexamethasone one-off, but don't seem to have quite have settled, and then I've given them some preg. But most advice is if they need dexameth, then it should be an A&E, because it's a level that they should be just assessed there.
Okay, thank you.
So, case 3, this is a 5-year-old boy. He's had a temperature for a week. He's had some conjunctivitis, but not the discharge-like conjunctivitis, more the red eye, sore looking. He's tired. He's not been able to go to school. What other questions would you ask?
Does his eye look swollen?
Not swollen, just red.
Does he have any skin rashes anywhere?
Good one. Whereabouts especially would you want to know? Might he have a rash?
Maybe on the chest or thorax?
Okay, yep, they may do, but it's more somewhere else. Anyone else have a guess what I'm thinking of and where they might have a rash?
The hands.
That's right, the hands and the feet. What else might you see at the hands and the feet?
Flaky skin.
They could have flaky skin. Anything else?
Vesicles?
Not necessarily vesicles, but they might have some swelling of the hands and feet. Where else might they have something a bit rash-like going on? The mouth, yeah. And you might see some cracking of the lips. What condition do you think I'm thinking of here, guys?
Kawasaki's?
Absolutely. Absolutely. So the specific things here we want to ask about, I would have said foreign travel, but well, maybe this week people are going foreign travel. I'd want to know what degree of temperatures, whether the temperature is responding, okay, and whether he's got any abdominal symptoms. Okay, that's the other area to think about. So this is our little kid. He's obviously not very well. Okay, and so we're thinking first about Kawasaki. So Kawasaki usually presents around sort of 5 years or just under. I've had a case, a 10-year-old and an 11-year-old, so it does happen in those, but people often talk about under fives. It's a vasculitic disease, so it affects the vessels, and most importantly is that we need to pick it up early because of the effect it can have on the coronary arteries and the aneurysm formation. So suppose you're a third of patients who have Kawasaki's and it's not picked up can get this to happen. So the things to really look out for in these situations: the cracking lip, the strawberry tongue, the edema of the hands and feet. The peeling skin is a late sign, and that's late, that's worrying, okay? And they'll have some lymphadenopathy, especially around the neck. Of course, differential diagnosis, scald skin syndrome, toxic shock, scarlet fever, measles, of course. And of course, we all know that there's an issue about measles at the moment because there are a number of kids unvaccinated, and we're getting some resurgence of that. Any kid with Kawasaki's has to be admitted for IV immunoglobulins and aspirin. Now, the interesting thing is, and I'm sure you've heard about it, is the multi-system inflammatory syndrome in kids. We actually had one of the first cases that ended up in GOS and was in there for weeks. The slight difference is it's inflammation, not vasculitis, but it has a lot of the same signs and symptoms: abdominal pain, fever, a bit more vomiting and diarrhea. Rashes could be anywhere, but again, the cracked lips, the red swollen eyes and swollen hands and feet. And again, it's the cardiac issues again with aneurysm formation. And again, it needs to be treated, in this case though, IV immunoglobulins plus corticosteroids. We were finding with these sort of alpha and delta variants of the COVID that this was happening a little bit more. There weren't many cases, but there were some. We haven't had any cases with the Omicron variant, and I hope that continues to be the same. So I think if you were to see an unwell kid like this now, I'd be going more with the Kawasaki's now. But either way, they both need to be urgently admitted. They are unwell, and this risk of coronary aneurysm formation is an issue. Any questions? Anyone? Do you guys know much about the multi-system inflammatory syndrome?
Not too much.
Yeah. It's. I think thankfully most of the kids did get into hospital quite quickly. When we had the Camden COVID response unit, we had one kid turn up really unwell, and we sent him in, and he ended up in GOS there as well. I think the one that was actually from our practice directly, the parents sensibly took him straight to A&E when he was unwell. But I have seen a couple of cases, but not many, which is thankfully good in that situation. But it's just to think, if you start seeing these red cracked lips, red eyes, any swelling of hands and feet, and sort of abdominal symptoms, this multi-system thing, that kid is sick and needs to go in. Okay, so case 4.
Can I just ask?
Yeah, go ahead.
Logistically, in these situations, do we need to discuss with peds, or can we just send an ambulance straight to A&E?
I would be sending an ambulance straight in personally, but I would probably phone the ped and say, this kid is on the way. I am worried they've got this. Please, can you be ready for them turning up in the ambulance? So, any other questions?
I was just wondering, just as a clinical picture, does that sort of develop really quickly and the kid is really sick very fast, or is that something that's sort of brewing over a few days and then might have a few sort of GP visits and then you think, oh no, after day 5 or something?
Amazingly, I would say in the cases of Kawasaki that I've seen a couple that were proved positive and I've seen a couple that was negative, that usually the kids are unwell but don't seem that really unwell. E.g., they're keeping some fluid down, they're passing some urine, they might be eating a little. So the parents haven't sort of rushed to us, and it's usually that the kid is still unwell and it's day 5 that they're going, my kid is getting worse, not better. that they then call up. And it's, it might be day 6 or something, or day 7, my kid's been unwell for a week. And it's getting that full history out of them. And again, that's why I say under 5s, I like to see them, because sometimes unless you see them, the parents don't tell you about the slight swelling or the slight rash on the hands, or the slight cracked lips or the red tongue or anything like that. So that's why I'm so keen that these kids should be seen and should be basically booked straight into emergency clinic. Kid comes straight in. You can then examine them fully, checking tongue, lips, hands, feet, looking for everything there and then. Because if that parent has told you they've had abdominal symptoms, they've had their eyes are red, their tongue is red, their lips are cracked, they've got some signs on the hands, you can just send them straight in and say, this is Kawasaki's until proved otherwise. The hospital can always turn around and say, stupid GP, this wasn't. But we don't have the ability to do blood tests, scans, the echo that they need. And, if there's a risk of it, then they need to go in and have bloods and echo straight away. And so, once they've got those tests, they can say yes or no to it. But until those things are done, it's Kawasaki's or multi-system failure, and they need to be checked out. So I very much, again, have that thing that if you are at all worried, you speak to the consultant ped, or you send that kid in, because you really don't want to miss any of these cases and it being late. It's the safety netting here is if they had been in contact with us, let's say day 2, and at that time, a bit of abdo symptoms, a bit of temperature. My view to the parents in these situations is if a kid is still getting ongoing temperatures from day 5, I want to know about it and I want to see them. So I have that sort of open conversation with them saying, this is probably viral, all going to set, all going to be fine. But if they are still unwell on day 5, I want to know about it. Okay. And they can get back to me and my reception would know to put them straight in to see me without any problems. And I think it's having that maybe open relationship with receptionists to know that this kid has been seen a few days before, and that they can go into the notes and see that if this kid is still unwell on day 5, they must be booked into emergency clinic. They can then act on it and do it. So I think that's an important thing to have sort of set up and aware of that. Any other questions? Anything else? So let's do case 4. We've got a 7-year-old girl. She's got a temperature 38.5 for 2 days. The parents are worried because she's had a previous history of febrile fits and she's complaining of headache. What would worry you and why? And what would you ask about?
If she's had any like photophobia, neck stiffness, I'd be worried about either something like meningitis or she just has another febrile seizure.
Absolutely. What age do most kids grow out of febrile fits?
Is it by 11?
It's usually earlier than that. If they were still having febrile fit at 11, I would be getting them checked for other causes and would be worried that something they had epilepsy underlying.
Is it about 5?
Yeah, 5, 6, they usually grow out. So if they're still after that, then I would definitely get them seen by a neurologist, pediatric neurologist, to get them checked out. So when I was first doing this presentation, it was all about how would you assess this? Would you do a telephone consultation? Would you see them face to face, or would you do a video? I would say now, this kid with this history, complaining of a headache, this kid should be seen by you guys, as far as I'm concerned. These were a list of things that I would ask in this sort of scenario. Are they able to play? Are they doing their usual things? Are they going to school? Because if they're going to school or nursery, then the kid can't be that unwell. Schools and nurseries are pretty quick at sending them home. If they're eating and drinking, the number of times parents have told me their kid's really, really sick and they walk into my room eating a bag of crisps or eating a chocolate bar, then I know they're not that unwell. They're still passing urine normally, and I'm talking about 2 to 3 times a day. I'm reassured. A good thing is if the temperatures come down with Calpol or ibuprofen, again, I mentioned about my website that I like. If they've got any limb pain, that's definitely showing some systemic thing going on, and I definitely worried about that. In viewers earlier when we were talking about etc., always double check if they're up to date with their vaccinations in view of things like measles, etc. We've had a few cases of parents who, of course, have refused the MMR over the years, and we've had quite a few cases of measles, mumps, and rubella. Hopefully, our MMR rates have gone back up. I'm sure you all knew about the guy from the Royal Free who was our guy who decided the MMR was bad, but I won't go into that unless sure you have read about it in the past. And the skin changes, rashes are really important, but it's also skin changes around the lip, in the mouth, etc. So our 7-year-old, when they came in, was absolutely fine, really, really well. She had a slight cold, but was on good form, and I could reassure that with her age, she was unlikely to have any more febrile convulsions, really, and I'm sure that she would just recover in a couple of days and absolutely fine. Any questions? Anyone? Nothing? You're all okay? So I'm going to move slightly on to sort of more adults. Okay. Now, I'm sure you've all probably know about the new scoring system and probably have used it a lot in hospital. Is that right?
Yeah.
Anyone?
Yeah.
So you probably use it a lot. Now, every time I phone up for an ambulance, they always go to me, what's the new score? And I'm going, don't know. And I'm not very good at scoring this and working it out. But it is being pushed out more and more into primary care, although it's never been assessed in primary care. It's only a secondary care tool. The ambulance people do use it. I think for me, the important thing are oxygen saturations in patients. Are they desaturating? What's their respiratory rate? Either end. And are they tachycardic or actually bradycardic? And of course, if they've totally lost consciousness, I know I've got an issue. And temperatures are never something to, everyone often, or parents often say, and people say to me, oh, what height of temperature should I be worried about? It's more the speed of going up with the temperature, and if it's not coming down with medication, it's more of an issue. So you guys will be well aware of how to use this much better than I am, but as I said, it's coming out to be used a lot more. And that's just the scoring for it, and how quickly to get people seen, which you probably know all about. And they're talking about how to use it. When we were running the Camden COVID response unit, I had to start using this for sending, when I was going to send people in thinking they were COVID, just to get an ambulance a bit quicker if I was telling them that they were over 7. So this is our first case. We've got a male university student. So who of you was at the student practice? You may see loads of these living in hall of residence. They're sweaty, they think they have a temperature, they've got an achy neck and a headache. So you can shout straight away at me, what is the most likely diagnosis?
Meningitis.
Absolutely. So how would you go about differentiating this just from this guy's got a really bad hangover?
Has he had any alcohol?
Absolutely. So yeah, he's probably drinking last night. I think most university students, I'm not saying all, but quite a few, probably drink most nights, especially in the first couple of weeks.
Is there others that are ill?
I missed that, sorry.
So he lives in residence, so is there anyone else who's ill or who has been ill recently?
Fantastic, excellent. What else specifically are you going to ask him?
Did he have his ACY vaccine before he started uni?
Well done, absolutely. Now, if you ask my son that, he wouldn't know. He would look at them or go, I haven't got a clue, had vaccine, no idea what I've had. And that is the slight problem with a lot of them, is that they haven't got a clue what they've had. So the men ACY WI vaccine, okay, is usually given at school. Years 9 to 10, which I would never know what year 9 to 10 is. It basically means when they're about 15 and 16. They usually get a diphtheria tetanus booster as well. But some kids may say, I don't remember having any vaccines around that age. So it's trying to ask them at that age, did they remember having vaccines at school? Now, if they miss it at school, they can have it at their GP. So all students should register with a GP, and they can have the vaccine up to the age of 25. I don't know why they're not allowed it after 25, or if they have to go privately. Not sure about that one. Okay, and again, when we're checking for this, we should also check to make sure that they've had 2 doses MMR, because they can also have that at the same time. Okay, so it's just worth being aware of that these people, because if they, although be careful, of course, it's not 100%. And if this young lad, you know, and again, I would be thinking about just having a quick look at him. If he really did have temperature, photophobia, neck pain and headache, even though he's, let's say he says he has had the vaccine, or it's on the system that he's had the vaccine, it's not 100%. So it would still be worth sending him in to be reviewed if you thought there was any possibility of that. But if when you came to see him and he didn't have a temperature and, you know, no photophobia, okay, then I would probably be reassured. Okay, so 22-year-old female, she's got acute abdominal pain, right-sided, had it now for about 24 hours, nausea, feels like she wants to vomit, but no diarrhea. What differential diagnoses are you going to come up with? Do shout them out.
Appendicitis or ovarian event.
Excellent. Anything else? Anyone else?
Pregnancy.
Sorry?
Pregnancy, ectopic.
Well done. Fantastic. Any others? You should be able to get quite a list. Could just be something really simple. IBS. I've had a couple of patients who presented like this and it's just been constipation. But PID, appendicitis, ovarian cyst, torsion, etc., ectopic pregnancy, salpingitis, Meckel's diverticulum, mesenteric adenitis, inflammatory bowel disease, duodenal ulcer, and there are more. These are the commonest ones, okay, in that sort of order, amazingly enough. Okay, so if you were, how would you assess her? Anyone?
Do you mean like an A2E assessment or like history?
I mean, however, would you bring her in? Would you try and do it over the phone?
I guess it'd be worth just bringing her in just to examine her in case it's an acute abdomen versus if it's just something like IBS or constipation.
Absolutely. And when you brought her in, what test would you do very quickly?
Pregnancy.
Yeah, absolutely. Because you get a pregnancy test and she's pregnancy test negative, we can at least pretty much rule out the ectopic pregnancy. All right. And as you said, examining the abdomen, I think you really need to here. If you've got any slight rebound guarding in that area, you're going to need to send her in. Okay. And probably, like most of this, you want to find out, did the abdominal part start centrally and has now gone down into that area? Then you're going to think more appendicitis. If they've had any previous gynae problems, gynae issues, you might be thinking about the cyst or PID. What's their sexual history? Have they had many partners? Do they use contraception, e.g. condoms? I'm thinking specifically here to reduce the risk of PID. Okay. In view of how the pain came on, is they getting pain into the back? You might think about a duodenal ulcer. Okay. As I say, most of these are more benign, but I have had people where I was so sure it was an appendicitis and I've sent them in and they've just been found to have constipation. But you know, any risk with appendicitis, it's fine in hospital. You can get a CT abdo, you can get abdominal ultrasound, you can get a CRP, all really, really quickly, and you know what you're dealing with. But here in general practice, if you're getting any guarding rebound or anything like that, okay, I would be sending them straight in. The other thing you can do as well, do a quick urine check. I mean, I'm not big on dips. I think they're useless unless you're looking for red blood. Okay, anyone who's had anything red, beetroot, anything, comes up with blood. So if I'm ever thinking about a urinary tract infection, you should always be sending the urine off and not doing a dip. But in acute situations, you need that urine to do the ectopic, so you might just be checking it for glucose quickly, something like that. Okay, but if you were at all worried with a young girl like this, with that area, but I can bet your bottom dollar, you try and refer them into the surgeons. The surgeons will say it's gynae, and the gynae will say it's surgery. So you'll have great fun having to get them in. All right. But they need to be seen, and I would go surgically myself first, because I think that's slightly more at risk here than more the ovarian. If they've had a previous history of loads of torsions and twists, there is the emergency gynae, so you can send them and they'll scan them on the day. So that is possible. All right. So yeah, we will see. So case 3. 35-year-old female, onset of sharp light chest pain with some associated shortness of breath. What is the worst likely diagnosis that you're thinking of? Come on, guys. What's your worst? What are you thinking?
Is it a PE?
Absolutely. That's what you're thinking of, especially combined oral contraceptive pill. She's been on a long haul flight or a long train journey, something like that. What other risk factors increase her risk of a PE?
Her weight?
Excellent. Her weight. Anything else?
Any recent surgery or immobilization?
Absolutely. Anything else?
Any relevant past medical history?
Yeah.
So like if she had antiphospholipid syndrome or something more obscure like that.
Absolutely. Absolutely. My lady, what I'm thinking of, was pregnant. And she was then found out she had her most horrendous PE, and she was allergic to most of the different heparins, and she must have tried about 3 or 4. She had allergic reactions to them, and so she was on the weirdest heparin I'd never heard of before for most of the pregnancy. She's now on warfarin. Okay, and I mean, the only thing that we had, there was a family history of someone having had a PE in the past, but that was the only one. And they think she must have some underlying cause for it. But because she's on heparin, they can't do all the blood tests. And then they had to put her onto warfarin. And again, you can't do all the tests, but they're trying to see if they can find out exactly what's caused it with her. But it was an interesting issue. So just quickly, risk factors: age under 40, 1 in 10,000, 60 to 69, 1 in 100, and over 80. I think that's meant to be 1 in 10. Sorry, I missed there. But yes, the weight, as someone said, that's a big issue, increases it by 3. Previous clot of any kind, they've got a 5% recurrence rate each year. Malignancy, of course, is the big one, 7 times the increased risk. Hormone therapy, combined pill, 3 times. HRT, 2 times risk if they're on the tablets. Okay, if they're using the gel or the patches, that's not the case. And tamoxifen, guys, thinking about all the women who are now on tamoxifen, they've also got a 3 times increased risk. As I said, pregnancy is the big one, and yes, the hospitalization, immobility, etc. And the plaster cast is a big one, especially leg. And of course, surgery is a big risk as well. All right. So this is my last case. Okay. This is a 73-year-old gentleman, usually fit and healthy. He was actually a security guard at the Tavistock. Had some hypertension, but his daughter phoned up saying that he was doing the weirdest things. He was getting up in the middle of the night and opening all the cans in the fridge and putting them around the kitchen. He was getting out some cleaning stuff from under the cupboard and trying to clean his glasses with it. He was saying that everywhere was dark and wanting to turn torches on and light candles everywhere. How would you assess him?
And is that an acute onset, or is that more?
It's acute. It's about a week of these really weird, strange behaviours. I mean, they were just two examples of the weirdness he was doing. Just not his normal self. Knew who they were, but was just doing really weird things. What other questions might you ask?
So if there's a history of any infectious symptoms.
So what might he have had, or the family might have had? So the daughter now tells you that she had COVID 2 weeks ago. Okay, they didn't think to check him because he doesn't have a cough, he doesn't have temperature. Okay, so now you're going to tell them that he needs to be checked. Okay, but what other things might you want to know about?
You'd be thinking of a sort of managing it along an acute confusional state, but I guess you want to know from a history, like, has he got any like vocal symptoms at all, or are you dealing with, something where you're going to need like some bloods and stuff?
Yeah, so I know this guy quite well, so I had a chat with him on the phone, and he sounded his normal self. His usual thing, told me a dirty joke, as he always does, and he seemed himself. But most of the strange behaviour was happening at night, okay, and it just was weird, really weird. So I did as you said, I did a full screen. So I confess, when I'm doing a full COVID screen, I put in a D-dimer. His D-dimer came back over 2,000, so I was PE, straight into hospital. But he didn't have a PE, amazingly enough. He was COVID positive. And that we believe that this strange was all due to COVID. He went in the first time and they sent him out saying, oh, there's nothing that much wrong with him. I was sure there was still something going on, and I couldn't understand why his D-dimer was still so high. And when he went back in again, they thankfully then did a CT head, and actually they think he's had some strange little stroke, and we think it's secondary to COVID. But I just wanted to present him because we are finding with COVID, yes, you have the traditional way people present, but there's a lot of people who present in really weird, wacky ways. And I know people might think, oh my God, don't ask him, I don't think it's COVID. It's like, unless they've done at least a lateral and I prefer a PCR, to know if they are, especially if someone else in the family has had COVID. He was fully vaccinated, he was up with everything, but it was before Omicron, so I'm sure this was a Delta variant. But I just want people to know that a lot of people are presenting in weird ways, and along with the long COVID, a lot of people are presenting in different ways. Okay, so that's my little presentation. Any questions and anything you want to bring up? Anything? Any of you guys seen anything that you've been wondering about, wanting to know about? Anything that's happened? Many of you seen any COVID cases?
Yeah, I just did 3 months of ID, and actually most of the elderly patients who come in who had COVID all had some sort of delirium. Yeah, none of them really had any oxygen requirements or any of the classical respiratory symptoms. Most of it was just delirium and frailty.
Yeah, so it's good to know it's not just my poor gentleman. Yeah, Tisa Sweetie, so that was great. Anyone else have anything? Anyone have any questions they wanted to ask about anything?
Can I ask a quick question?
Yeah.
I just wondered, last time when I was in general practice, it was back at the sort of start of COVID, and all of the services sort of migrated to migrated to the Whittington.
UCH and the Royal Free are now back open. And that whole palaver about the Whittington was a total failure, thank God, in the sense that, so the Royal Free and UCLH are now open again for peds. Okay, so yeah, you've again got I must admit, I use the Royal Free, so we have a paediatric consultant there that I can speak to. I'm taking it UCLH does as well, they must do. So that is back open, but yeah, that was a nightmare, only having the Whittington. And if the kids turned up at the Royal Free, they then had to be sort of ambulanced up to the Wit. It was crazy. Anything else, guys? No one have anything else? Anything else you feel I should address or talk through with you? No? Well, we're nearly an hour, and I always think that's probably enough for most people. And you probably can go and enjoy yourselves and have a coffee break and do things. But enjoy back in general practice, enjoy your placements, and hope that at some point we will get to see more people face to face at some point. Okay then.
Thank you.
Thanks very much.
Thank you.
Thank you.
Bye.
Bye.